So with this, I move on to another imaging modality, which is angio-OCT or about this technology. So I'm just going to give a very simplified version of what it is. It is actually a new generation functional OCT. So when you do the scans too many, you can actually see the movement of the blood in the retinal vessels, and you can capture it to simplify it, which means that with the fluorescein, we were injecting the dye and we were visualizing the flow of the dye within the retinal vessels. Here, we are not injecting any dye, we are just capturing the flow of the blood within the retinal vessels, and that is OCT angio. So, what are the advantages of the OCT angio? First is you don't have to inject the contrast. Second is the visualization of the vessels is very good. So I'm going to skip some of these basics because you can read it anywhere. But angio-OCT, when we compare it with the fluorescein angiography and ICG, there are a couple of advantages the technique has. Both fluorescein and ICG, they are invasive, they require injection of the dye, and you have to wait for 10 to 30 minutes till the time you see the pooling of the dye or the leakage or the staining of the dye. Whereas in angio-OCT, you can do it very rapid. It takes about 6 seconds to do it in one patient. You are not injecting, it is non-invasive, you can get the thing. Now where is the problem? There are two problems. One is it takes up a scan of maximum of 8 millimeter cube. So you are by and large restricted only to the posterior pole, and you cannot really use it as a sole agent for because you want to see what is happening in the rest of the retina. And the second thing is, contrary to what we have, the OCT angio shows us two planes, superficial as well as deep. So I'm going to show some of the examples. So we have to relearn to interpret our angiograms. So as I said, the images I'm going to show you are from the AngioView software, but there are many commercially available angio-OCT machines right now. So, but the one which I'm going to discuss is basically from Avanti, because this is what we have, the OptoView, in our system. Now this device obtains volumetric scans of 3x4x3x4 A scans, which is approximately 70,000 A scans per second. And the software gives us the option of evaluating these scans. And as I said, the maximum area we can capture is 8 by 8. But again, when we go to 8 by 8, the resolution really goes down. So ideally, it is generally 3.5 or 6 millimeter that works. This is what it looks like. Now, this is the superficial plexus, which we were seeing all along on fluorescein angiography. And this is what we are very, very familiar with when we are looking at the microaneurysms or so many other things. This shows two plexuses because this is en-face. This is not the topography. So we have a superficial plexus and we have a deep retinal plexus. Now, when we are studying the retinal diseases, it's not we are seeing there is a leakage, there is a staining, there is nothing. We have to kind of retune to looking at the disease pathology in the superficial plexus, in the deep retinal plexus. Then there is the outer retina. The outer retina is kind of, we all understand, not much blood vessels. So we don't see in the normal stage in the outer retina, we don't see much happening. Move on to the choriocapillaries. This is what a normal choriocapillaries would look like in a normal patient with a normal scan. You can put these on top of your image and you can see what area corresponds, what you are seeing on angio-OCT to clinically. Besides doing this, you can also have the en-face OCT. And many of you, it's instruction course, so I'm not going into very high-tech stuff. What is basically en-face? En-face is very simple. You imagine holding an onion. So if you keep on slicing it horizontally in the form of the rings, imagine eye is an onion. So when you get rings, that is en-face. So this is what an en-face image of the choriocapillaries is. So you can, advantages it gives you, you have the OCT, you can select the segmentation slab where you are putting. You can get your en-face OCT, you can get your angiogram in the form of the superficial and deep vessels. So let's see how does it help in diabetic retinopathy, because that is what we use the angiography most of the times for. This is useful in evaluating foveal avascular zone and perifoveal capillary intercapillary areas. This is really very good in picking up the areas of capillary non-perfusion. This can visualize the majority but not all of microaneurysm, and here is the problem. If you really want to look at the microaneurysms, you have to do the fluorescein angiography, because on angio-OCT, you might miss up to 30 to 40% of the microaneurysms, and this is the interim analysis of the ongoing trial which we are doing with Giovanni Storangi. We don't have the final thing as yet, but the publications also show that microaneurysms are not seen so well. Now the questions will be why not? Because this by principle OCTA is limited by the slowest detectable flow. So if in the microaneurysm nothing is flowing, it's not going to pick up the microaneurysm. So many a times you might miss that. Other than that, it can pick up the abnormalities which are not seen on FA, such as the areas of the non-perfusion. In the area where fluorescein is showing perfusion, OCT angio is showing non-perfusion. So there are some additional findings. We do get areas of reduced capillary density and increased vascular tortuosity. Now, example here is diabetic macular edema. You see the fluorescein is showing some microaneurysms, and these block fluorescence, but when you see angio-OCT, these dark areas here, these indicate the areas of the capillary non-perfusions which we are not seeing on angiography. And as Anand mentioned, we are seeing these vessels within the foveal avascular zone. So whatever we used to call avascular zone, we no longer know whether that is avascular or not. This is the example of the another patient. Now see the context. There is a cystoid macular edema. You see it on angiography, you see it on OCT, and this is the segmentation slab which is passing through the cyst. So logically you should see some cyst or something, but if you are expecting to see it on angio-OCT, we are probably wrong, because it is measuring the flow in the blood vessels. Okay, so it's not going to show us the cyst. So getting confused that we are having almost a normal angiogram, normal looking angiogram in a patient which has cystoid edema is not the fault of the technology. It is our interpretation, and we have to learn which information to gather from which modality. Now we have en-face OCT incorporated into this. That is the purpose of this, and you see those cystoid spaces beautifully in the en-face OCT. Over the quickly next 5 minutes, I am going to run through some of these slides. Now the detection of optic disc new vascularization. This was to my mind one of the most important things, that if I tell my technician or I put it as a screening device, can it pick up the new vessels? I won't go into the details and all, I'm just showing you the images, because most of the things which I'm talking about would come in print very soon. Now see here, this is NVD. You do the fluorescein, you do see NVD here very nicely, but in the late phase, everything either becomes too fuzzy or you don't really demarcate the NVD and see the angio-OCT here. You see the entire extent of the NVD, and even when you are monitoring the regression pattern, it takes you 6 seconds. You don't have to inject the dye, and it's non-invasive. Another example of NVD, there is NVD, fluorescein shows a beautiful leakage, but if you see here, the lower nasal quadrant, maybe on fundus photography, I do say probably there is something, but the fluorescein really doesn't show there are vessels in this quadrant, in this temporal quadrant. and see on the angiosity. The extent of the new vascularization is far more than we can see. One practical tip for those of you who are doing or who are going to do angiosity is the new vessels rise above the surface. So when you are trying to see the new vessel, it is good to go into the vitreous phase. And we have submitted for publication differentiating collaterals from new vessels. The collaterals do not rise above the surface. So if you are looking for the collaterals, go to the retinal peripapillary frames. Don't go to the vitreous frame. And in a patient with CRVO, that will show you whether that is collateral or new vessels. For example, this patient here is an example of new vascularization. And you can see it is raised above the surface, and you can take the en-face osity of the new vessels. Whereas for collaterals, you have to restrict yourself to the too many slides. I won't show you all the things, but one thing I'm going to show you, its role in the choroid. Because all of you who practice choroiditis, it's confusing. This is coming up in retina very shortly, the data. But why is choroiditis confusing? Choroiditis is confusing because in the same eye you have some healed patches, some active patches. Fluorescein starts leaking the dye. The dye leaking causes so much of confusion that you can't even look at what's happening. ICG is very good, but ICG is difficult to interpret, is expensive, and is not routinely available. So we did this study to compare angio-OCT with ICG. Now you can see we selected some of these lesions here, the one with the white arrows, and these were the active lesions on autofluorescence. We did their imaging on fluorescein. Now look at the fluorescein. You do see a lot happening, and you do make out that probably these lesions are active here. ICG shows these lesions are hypo and hypo. So it means these two lesions which we are looking at are active. This is the angio-OCT. The retina is absolutely normal. Both the superficial outer plexus is fine because everything is happening in the choroid. And when we go to the choroid, there are areas of choroidal non-perfusion which is corresponding to those two active lesions. And you do see very early new vascularization happening here. So this is something new finding that we are getting. But when we correlate the angio-OCT with ICG, and we have done in more than 25 eyes, it does correlate very well. I don't think I have time to go on, but this is just to give you an idea that this is something new which is coming up, which all of us will be hearing more and more about, and just to familiarize you all that it's good for picking up the retinal vessels for some of the capillary non-perfusions, and extremely useful in evaluating choroid because we all are not so good in interpreting ICG. If there are any questions, I would be happy to take it, and then we have Anand giving the last talk of the instruction course about wide field fluorescein angiography. Because I said one of the limitations of OCT angio is it can't do the wide field. So what I am doing in my practice is for posterior pole lesions, angio-OCT, and for the periphery wide field. So like Geeta said, you learn all the strokes, but when you are actually playing tennis, you have to use all the strokes. So it's not that we have one gadget or the other, we have to combine everything. Thank you.